Our next speaker is Dr. Chao Gan Yang, who is a professor at the Institute of Psychology in the Chinese Academy of Sciences, where his research mainly focuses on the resting state fMRI computational methodology, mechanisms of spontaneous brain activity, and their applications in depression. And today, Dr. Yan is going to be speaking on research progress and blueprint of the Depression Imaging Research Consortium Direct Phase 3. Thank you so much.
Thank you, Amy, for your introduction, and thank you very much for the invitation, specifically for Dr. Zixuan Zhou's invitation. I was told by Zixuan that we will end this session before 6 p.m. our time, so that means we only have 20 minutes, so I will present as soon as possible. So actually today's session is we are talking about MR data liberation, sharing for a better future. So we have covered topics like FAIR principles, like BEAS format, like data-light and other analysis methods. So basically, for my talk is in a specific area in depression imaging. So how we share the data, how we do the data liberation. So this is, we have a consortium called Depression Imaging Research Consortium. We have a very brief introduction and talk about what we have done in phase 1 and what we have found in phase 2 and what we are going to do in phase 3. So because today's topic is more about the data liberation, so I will not go details why the MDD, major depression disorder, is important, and what's the current status of MDD diagnosis, or what's the scientific research is. But basically, myself is a brain imaging scientist. So what we are trying to find if we can use a brain scan to find any biomarker or guiding for treatment using functional MRI or structural MRI. And currently, we do not have that. One specific reason is we have lots of problem of data. Data is either small or heterogeneity. So in the future, we may think with the development of BEAS, data-light, and the big data, we can train some AI to help us better diagnose MDD or better treat. But first, we need to have a clean, organized, high-quality data. So how we go there? And also in Nature, there is also a paper talking about reproducible brain-wide association studies require thousands of individuals. So we do know there's argues about this point that somebody argued maybe we do not need 1,000 of individuals to have reliable associations, but we do think big data can help. So you can see lots of initiatives like HCP, ABCD, UK Biobank, and Enigma. And for depression imaging field, we do have some effort that, I cannot go details how constructed the consortium is through our software. So our software is like the BEAS or like fMPrep, the effort that we build fMR data processing software, DPAS or DPIB, which is very easy to use. And lots of people are using our DPIB or DPAS to process their brain imaging data, including lots of depression researchers. Then we search the literature and we email them that you do not need to share your raw data, as you have already published paper using our DPAS software. You just only need to share the final derivatives. And for your information, we have DPIB software. The DPIB stuff is compatible with the BEAS. So you have BEAS data, you can directly use DPIB stuff to process your data. And also, if you do not have BEAS, DPIB surface also helps you organize your data from DACOM files and convert them into BEAS format. So basically, is this is how we build the consortium. And in the phase 1, the consortium has accumulated 1,300 depressed patients and 1,100 normal controls. So this is currently our largest MDD resident fMR data site. And for the phase 1, we our mechanism is kind of data liberation or grassroots data sharing, that we do not have a big funding for us to organize all the data, but rather it's for the grassroots PIs. And our mechanisms, you do not need to share your raw data. We will train you how to use deep heavy software, and then your students or your junior faculties can use our software, analyze the data at the local hospitals, and you only share the standardized pre-processed results. So that's the raw data. You still have control, and the privacy concern is less in this kind of situation. So they only shared the processed results. And then using the processed results, we can do reanalysis or sharing all across the world. So this are mechanism we call the Alpha Maps project. So this is a project we did with the mechanism. And then we have lots of data, like have 25 sites, and this is sex ratio, more females than males suffered from MDD, and this is age range, and this is severity. And with this big data, this is scientific funding, but today we are talking about MR data liberation. I will very briefly cover. This is a first study is just using this big data to analyze what happened for the patients in their default mode network functional connectivity, because there's a lot of inconsistency of previous studies. Using this big data, we adjust this inconsistency that we found in depressed patients. The MDD default mode network function was reduced, but this reduction only happens in recurrent patients, not in first episode and drug naive patients. And this is published in PNAS. And later we also talking about, because the functional activity of depression brain was decreased, but what happened to their topological properties? And we found that both the global efficiency and local efficiency of depressed patients were reduced. So this may partially explain why they have reduced processing speed and reduced illness probably. And there are many more studies. I don't want to go details, like focus on the small word dynamic needs in the MDD patients, focus on the subtype in default mode network in depressed patients, and also in the asymmetry of depressed brains, and talking about in subtype of MDD, for example, for those with gastrointestinal symptoms. And if you're interested in, you can read our direct ConsorTium paper. So this psychoradiology paper reviewed what we have found in the recommended project and what we are going to examine in future. So we have a direction for future direct research. So we are actually in the later part of my talk, we talk about what we are going to do in the future. And interestingly, because we are talking about MR data liberation, so we need to liberalize this data that we openly share the rest of MDD data, because these are not raw data, so we do not have privacy concerns. These are the processed data, and we trying to accelerate open science in brain imaging of depression. And up to now, there are more than 300 international groups applied to use this big data in their studies. So the data users across all the world, including South America and Europe, India, China, etc. Now, according to Google Scholar, at least 200 studies mentioned or used recommended data, including some papers in molecular psychology or Nature Mental Health. So we think open sharing data can have a good impact of the field. And in the direct phase 2, I'm going to talk about a very specific study with this big data. So actually the phase 2, we are concerned in one situation in MDD, because the depressed patient, at least in China, only 0.5% were treated adequately. And even for those people, after initial antidepressant treatment, only two-thirds of them cannot achieve effectively symptom relief. And for those two-thirds, they will consider change medication if there's no partial response after 4 to 6 weeks. But still, there are 30% of patients have treatment-resistant depression. And for those treatment-resistant depression, there is one cure, is TMIs. TMIs itself is established, MDV-approved, safe and effective treatment that can alleviate the symptoms in patients with a treatment-resistant depression. But the problem is, where do we put TMS core? Which brain region should we target? So there's previously just find M1 and measure 5 centimeters find a spot, but you know your brain may be smaller than mine, so the 5 centimeters means totally different. And some people propose maybe you can use EEG cap to use F3 electrode, or use anatomic targeting, or use PET. But we do think in the future, we should focus on all functional brain activity. And each of us has unique functional activity. So we should use our functional activity to find personalized target. So stimulating individual target in depression can improve the therapeutic effects of TMS, but how to target? And there's lots of methods like 5 centimeter methods, F3 beam, and use anatomic targeting. And this is a very famous paper by Michael Fox group that using SGACC, which has some significance in depressed patients' brain, and uses subgenual SGACC used dual functional activity and found the most negative correlates on DRPFC. And this is related to the treatment efficacy. And but only very few studies use individualized resonance fMRI because partially the SGACC is pretty noisy. And so there's some other method trying to figure out the problem. So there's one thing maybe you are aware is that a therapy called Stanford Neuromodulation Therapy, SNT, this one has already got the FDA clearance. As we have the FDA clearance, this is possibly future treatment for MDD. And we do find that the paper reported that they found in the treatment group, active SNT, they have very good treatment efficiency. But in the control sham group, there's no treatment efficacy. And what they have used is one is accelerated, but very high intensive treatment, 5 days. And in the 5 days, each day they have 10 treatment sessions, 10 minutes treatment and 15 minutes rest and so on. And then they also use the individualized use SGACC to find the best target. And then find the target combined with the accelerated TMIs, they have very good effects. And through individual target localization and accelerated neuromodulation stimulation, SNT achieved a response rate of 90% in patients with a treatment-resistant depression and got FDA clearance. So actually, the SAINT therapy is kind of patent protected. And in the papers, the algorithms is not very precisely and clearly declared. So the better method we should, maybe one is reproduce the algorithm, and one we should have, we have a big data of depression. Maybe we can use big data to guide on the individual data and have precise and stable methods. So we have a large sample as we previously described in the direct consortium, and then we use in phase 2, we have 1,600 MDDs and 1,300 HCs. So we use an approach that we use large MR data, and we process with the deep surf, and we got the SGACC connectivity map. We do combat and do a statistical analysis. Once we got a statistical analysis, we can use this GAD dual regression to have individualized TMS target. So this is our SGACC seed, and we have different definitions and different DFPC definitions. And what we have done is using this whole algorithm to get a dual regression. And what you find exactly is use this big data. We do find SGCC abnormality function connectivity in DRPFC. And also this abnormality in DRPFC connectivity has an association with a clinical improvement. So we think if the difference of SGCC functional activity between IDD group and HC group, can we use the difference to get through find individualized target? So we use this dual regression method to find the target. And this dual regression method, I think you have know some about it because ICA sometimes use dual regression. And what we found is use this dual regression because if you use group difference map, you can have only one target for each subject. But if we use this individual target guided by big data group difference map, then each subject have a different target. And this target, interesting in a data set that we found has a negative correlation with the clinical improvement. So that means is the bigger the difference, the off-target difference, and then you will have less treatment efficacy. And also we checked using mean MDD or using mean HC, the less effect. And we compared our own implement with the SNT method. So actually all big data guided individualized difference methods has bigger effect than the SNT. So what I think about is this true? Is this really can used in future treatments? Then we need to do clinical trial. So we now in the direct consortium, we have a trial that lots of hospitals participated. We have different algorithms, but we calculate the target and send to hospitals. For the hospital, they do not know which algorithm we used, and we use TMS robots to target to see how good in treating depression patients. So the phase 3 actually running out of my time. So basically is we do the clinical trial of TMS using our big data guided TMS individualization, and we do also using more data because we have found treatment effects in the brain. So we want to investigate the psychotherapy, medication, what effects on the treatment. And this is our also plan. And because we also developed DPIP fiber to do fiber tracking, so we also want to do some big data on DTI fiber tracking. And also our group have some illumination and the spontaneous source paradigm, but I cannot have time to go details, but we also do large scale collaboration. And finally, it's interesting way is we have a consortium for resting norm reference, because there's a Nature paper reported using 4 structural methods like a gray matter volume, subcortical gray matter volume, water matter volume, and the CSF, and using the tens of thousands of hundreds of thousands of people, and then build a norm. This can improve the diagnostic efficacy, but there's not too much Chinese data, and only full brain structure indicates no functional data. So we started in China because previously we also have this method used now as reference, can improve the data reliability. So we want to target more than 200,000 people in China to constructing the Chinese resident state function among non-reference. So this can help us moving towards individual abnormality detection brain disease. We have data aggregations and the pre-processed non-congenital disease application. So that also that different science, they do not need to share raw data. We will train them how to use our DPIP itself to process the data. And we hope for each brain region, functional structure, we can have a non-reference curve. So we have some initiative meetings, we have online conferences, and we did literature search in China. We have surveyed 3,000 papers in residency format, and there's over 200,000 participants. And over half using all software, DPIP and DPAS. So we hope that we can have a success in building a big data and have brain non reference, and maybe in the future can train some AI. Okay, I would like to thank you very much for your attention, and I'm running out of my time. Thank you.